usually, and I'll give you a review, quick review, in 20 minutes, it's impossible to cover the subject
FFR, iFR in 20 minutes, but I will do my best to give you basic knowledge, how we apply it in clinical practice in the cath lab to evaluate lesions, and how does it compare with other modalities of investigating patients with coronary artery disease when it comes to making a decision in the cath lab whether to leave the patient alone and not to proceed with stenting, because that's an extremely important decision. Most of us, when we do a cardiac catheterization, we based our decision on whether this patient needs a stent or needs surgery on how we assess the lesion visually, with looking at it. In invasive coronary angiography, of course, quantitative coronary assessment is sometimes indicated, but most of us look at the lesion and then make a decision that this lesion is mild, moderate, severe, and we even put numbers to this lesion. But this is, in a lot of situations, is not a correct way, because visual estimation is very variable. I can bring you an angio film and ask you to look at it and estimate the severity of a lesion. You can give me a number like 50 or 60%. And then I can bring the same film to you again the day after, and you will probably give a different number to that lesion. And if I show the same film to two cardiologists, interventional cardiologists, everyone will give a different assessment for the lesions. And this is especially true when we talk about intermediate lesions. If we look at severely stenotic lesions, and if we look at lesions that are 85 or 90 or 95% stenotic, then there is no big difference between assessment of different cardiologists. And the same applies also for mildly stenosed lesions. If we look at lesions that are 10, 20% or 30%, less than 50%, then again, sometimes we all agree on assessment of these lesions. But the problem is with intermediate lesions. When we talk about lesions that are between 50 and 90%, this is when we find a lot of variability, and therefore, we need a better way to assess these lesions in order to proceed with definitive therapy. So that's why FFR was introduced. That's why FFR is very important. And with FFR, which stands for Fractional Flow Reserve, what we need to do, what we basically do is we try to assess the impact of a stenotic lesion on blood flow. So the information that we need to know is that, is this lesion, it looks like a 70% lesion. Is this 70% lesion flow limiting? Is it a lesion that produces ischemia or that does not produce ischemia? And for that reason, I need to know if this information is obtainable. And we can do this with the FFR. When we exercise a patient, when we want to evaluate a lesion, what we typically do non-invasively is do an exercise test. With exercise test, you try to exercise the patient, you increase the flow, and then you can assess the patient, the impact of that lesion on ischemia when you achieve maximal exercise. So when you achieve maximal exercise, if there are no symptoms and if there are no changes on the ECG, then you can safely assume, as long as you have reached maximum exercise, you can safely assume that this lesion, in the absence of symptoms or ECG changes, that this lesion is not ischemic. So you tend to leave that patient alone. In the cath lab, you cannot do this. You cannot take the patient from the cath lab table and ask the patient to exercise. It's impossible. The patient is laying down on the table, draped, ready for a procedure, but then you are faced with a lesion that you need to assess. So the way to do it is you want to simulate what happens with exercise, and that is you want to maximize flow. And for that reason, in order to obtain an FFR, you really need to vasodilate the whole circulation, not only the conduit vessels, the epicardial coronaries, the LAD, circumflexor right coronary artery, but you also need to maximally vasodilate the microvasculature, that small blood vessels that are embedded in the myocardium. And that's why, in order to do FFR, you need to induce maximal hyperemia. And this is what we do when we infuse adenosine. So adenosine infusion, the purpose of adenosine is to maximally vasodilate all the coronary circulation, the conduit vessels, the major epicardial vessels, and also the microvasculature. And this is the only way to make a full assessment of a lesion. And it simulates, as I said, what happens when we do maximal exercise. So this is exactly what happens. We have a blood flow, and in normal situation, there is no stenosis in an artery. The proximal pressure is equals to the distal pressure in the artery, and if you subtract that, if you subtract the venous pressure, which usually is close to zero, you get the head pressure of the coronary artery in the absence of stenosis. When you have a stenosis, the pressure proximal to the stenosis is estimated at, say, 100, distal to the stenosis 70, so there is a gradient of blood flow. And in actuality, it's very difficult to measure flow, but then what they found that flow is linearly related to pressure. So flow in a coronary artery is related to pressure in the coronary artery. So you can easily measure pressure proximal to a stenotic lesion and measure pressure simultaneously distal to a stenotic lesion, and you can conclude that by estimating these pressure differences, you are also estimating flow in a coronary artery. So this is the basis for FFR. Now, we have to know that in guidelines, in recommendations, that FFR evaluation is indicated for all coronary lesions that are between 50 and 90%. Look at this. And oftentimes we found a lesion that we estimate at 70%, and we reflexly come to the conclusion that this lesion is significant and warrants to be intervened with. But any lesion that is 50 to 90%, before you proceed, before you make a decision to implant a stent or leave this patient at all, needs to be assessed. If a lesion is more than 90%, then you can go ahead and assess and plant your stent without doing any functional assessments. And for lesions that are less than 50% by visual inspection on a coronary angiogram, you can leave these patients safely alone. Look at this. These are two lesions, I think this is the LAD. This is a patient with stable angina, and this is the lesion under assessment, and this is a patient with an acute coronary syndrome. And both coronaries, if you look at them, you can probably come to the conclusion that they are the same. The amount of stenosis in this lesion is exactly like this lesion. But look what happens when you do FFR. This lesion had an FFR of 0.97, which means that there is no significant stenosis, and this patient can be safely left alone, while this lesion in a patient with an acute coronary syndrome with the same angiographic features has an FFR of 0.53. Severe stenosis with severe ischemia or reduction in flow distal to the stenotic lesion. And this lesion here in this particular patient needs to be tackled with a stent. So that's why angiography as such will not give you an answer to that question. And it's important to do this. If we look here, these are two studies that looked at death or myocardial infarction in lesions that have an FFR of over 0.75. The cutoff for these two studies, Diffuse and Reform, was 0.75. So patients who had a non-ischemia producing lesion with an FFR, a normal FFR over 0.75, did not have any increased event rate. So they did very well with medical therapy without intervening. This is in comparison to those with a FFR of less than 0.75, where the event rate was higher. So that's why patients with a normal FFR must be left alone. They shouldn't be touched with intervention, while those patients with an FFR of less than 0.75 or less than 0.8 should be treated. And again, this is just to show you why we need to assist these patients. If you look at lesions that are assessed at between 50 and 70% by coronary angiography, look at this lesion. When FFR is done, most of these patients, I agree, will have normal FFR, so they don't need intervention. But there's a substantial number of these patients that have FFR less than 0.8 who need to be intervention. There is no way that you can separate these patients from these patients just by looking at an angiogram. Again, if you look at patients with stenosis of over 90%, 91 to 99%, most of these patients have FFR of less than 0.8 and need to be intervened. Very few patients will have normal FFR and will not need any intervention. So it is safe to proceed with doing a stent on these patients when they have a stenosis of over 90%. But again, look at this patient population, between 71 and 90%. Now, most of us in this room who are intervention cardiologists, if they see a lesion that is 80% or 70%, will automatically, immediately proceed to putting a stent without even asking the question of whether this lesion is hemodynamically important or not important. But if you look at this category of patients and look at FFR, yes, the majority of these patients will have flow-limiting lesions with significant, with a reduced FFR, and therefore they would warrant treatment, but there's also a significant number of patients who do not need to be treated. All these patients above the red line did not need to be treated. So it's very important, critically important, to assess these lesions between 50 and 90% with a modality that assesses function and not only anatomy. طبعا in order to produce maximum hyperemia, there are different ways. احنا عادة usually what we use in the cath labs here and everywhere else is the adenosine. It can be given either intracoronary or it can be given intravenous. The classical way of administering adenosine is by intravenous infusion. The problem with that is that it's a bit expensive because you will need a lot of adenosine to give this patient, and that will cost money. So sometimes in certain cath lab, the adenosine is administered intracoronary, and you can do that. You can repeat the infusion for every coronary you need to assess. But adenosine is the classical way of inducing maximal hyperemia. You can use isorbate dinitrate, you can use papaverine, and also there are other chemicals or medications that can be used to induce maximal hyperemia. The way we measure it is usually when we perform diagnostic coronary angiography and we see a stenotic lesion and we need to assess that, it's preferable to exchange the diagnostic catheter with a guiding catheter. The reason is that you want to eliminate any friction, because diagnostic catheters have smaller lumens, and sometimes there can be friction between the wire and the inner lumen of the diagnostic catheter, so that may produce some artifacts. But if you exchange the diagnostic with the guiding catheter, and then you proceed by introducing deep pressure wire into the coronary distal to the lesion. The pressure wire has a sensor just at the junction between the radio-opaque end of the wire and the rest of the wire, and this is the sensor that measures the pressure distal to the lesion, and also proximally the pressure is measured at the tip of the guiding catheter. So you have a proximal pressure here, which reflects the central aortic pressure, and also you have a distal pressure measured by the wire introduced across the lesion. So this is why, and you get two readings. You get the proximal pressure and you get the distal pressure. In this patient with a proximal or mid-LAD lesion here that doesn't look quite bad, the FFR measured was 0.57. Again, just to show you that sometimes visual assessment of lesions in the cath lab is also problematic. This is a typical reading. This is before you give adenosine, before you induce maximal hyperemia. This is resting. And sometimes you can see that the gradient between the two pressures in the presence of a stenosis was not great. So there was a difference in pressure, but it wasn't great. And probably if you measure the FFR at this stage, it will be something like 0.85 or something, even 0.9. But when you administer adenosine, the pressure gradient increases, the difference increases, and then you can get your true FFR, which is in this case was 0.68. So here, if you measure without adenosine, this would probably tell you that the lesion is not significant. But after inducing maximal hyperemia, an insignificant lesion becomes quite significant. The cutoff for FFR is considered somewhere between 0.75 and 0.8. It was found that an FFR of less than 0.75 was 100% specific for indicating inducible ischemia. So if you have an FFR of less than 0.75, you automatically stent. There is no need to do anything else. And if you get an FFR of over 90, of over 80, again, you say that this patient is fine and you need to stent. There's a gray zone between 0.75 and 0.8, and this is where you have to use your judgment. You have to ask yourself, if the patient has angina, and you know that there is no other reason for the angina, and you're quite sure that the angina is angina, and it's not other types of chest pain, then even with an iFR of less than 0.8, you can proceed with your stent. But if the patient is doing fine, if the patient is exercising very well, the patient does not have any chest pain, or the chest pain is not produced by angina, then you can leave that patient alone. So that gray zone is for you as a physician to think about and assess per patient. In a study of 45 patients with angiographically dubious stenosis, intermediate stenosis, it was shown that FFR is much more accurate in distinguishing hemodynamically significant stenosis than exercise ECG, myocardial perfusion scintigraphy, and stress echocardiogram taken separately. So it is probably the most accurate test of assessing per vessel and per lesion ischemia. So what are some of the features of FFR? We know that why FFR is such a great way of assessing patients? Because every patient, every vessel and every lesion has a normal value, which is 1. Okay, it doesn't differ between patients, doesn't differ between lesions. FFR is not influenced, it's not affected by hemodynamic changes, it's not affected by heart rate, it's not affected by blood pressure, and it's also not affected by myocardial contractility. So irrespective of what heart rate that the patient has, blood pressure, or myocardial contractility, state of the left ventricular function, you can still obtain accurate FFR. And it also has unparalleled spatial resolution, because even if you do stress, can you tell from a stress test where the lesion is? Which lesion is producing symptoms? You can't. Even if you do stress nuclear, you still cannot tell which lesion is producing ischemia. You can say, well, we have anterior wall ischemia, probably related to the LAD. But what if the LAD has more than one lesion? Can you tell from a nuclear assessment which lesion is the one that's producing ischemia? You cannot. So this test, FFR, is the only lesion where you can study the vessels per lesion. If you have multiple lesions, sequential lesions in a vessel, you can tell for sure when you assess these vessels that the distal lesion is probably the lesion producing ischemia, or the mid lesion, or the proximal lesion. So the spatial resolution of this test is great. And again, just to highlight the specificity and sensitivity of the test, the threshold for ischemia was almost uniform in all of the studies, or some of the studies that assessed the threshold for ischemia. There were also in the range of 0.75 for iFR. Now, there are special features of FFR that we really need to pay attention. And it's not a simple technique that is straightforward. You have always to keep your brain open to certain caveats when you do this test. One of them is you have to know that FFR takes account of all the collateral circulation. It's counted for when you do FFR assessment. Take, for example, this patient with a very tight proximal to mid long lesion in the RCA that is obviously very tight and needs to be assessed. Now, this vessel receives collaterals from an LAD with a lesion here that we're not sure about. If you do this, and this needs to be done, if you do FFR before the canalization of the RCA, this is what you get. If you finish the RCA and then you repeat the FFR on the LAD, once you're done with the RCA canalization, you get a totally different value. Sometimes here it will tell you that the LAD needs to be fixed. And again, if you do the RCA, the value is different. And this has to do with the flow to the distal bed of the artery. So the presence of collaterals do not affect the vessel that is receiving the collaterals. It really affects the assessment of the vessel that is giving the collateral, the donor vessel, and not the recipient vessel. Now, one of the good features of FFR is that it's reproducible. You do it on a vessel in a patient. If you want to repeat it again, you will get exactly the same result. So it's very reliable in the same vessel in the same patient. Multi-vessel disease. This is one of the applications of FFR. For example, you have this patient with an RCA. You have a lesion here. You have a lesion in the mid-RCA, proximal RCA. Both appear to be tight. You also have a very tight lesion in the circumflex, and you have this lesion in the LAD. And now you want to make a decision. Probably the decision for doing the RCA is very easy. FFR was done, it was 0.43, indicating severe lesions. For the circumflex, it's obviously very stenotic, and the FFR is very low, 0.32. But this is a lesion that we're not sure about. Okay, it looks like it's an intermediate lesion. By visual assessments, probably it will be interpreted as maybe a 30 or 40% lesion. But again, when FFR was done on this lesion, it was 0.67. So all 3 lesions or 4 lesions needed to be tackled in this patient. Another patient, this is again with proximal and mid-RCA lesions. FFR is very low, so these lesions to be done. This is, sometimes you are faced with 2 sequential lesions, and you're not sure if both are significant. So in this patient, when the distal lesion was fixed and FFR was done on the proximal lesion, the reading was different, but again, still it was significant. Every time you have 2 sequential lesions, it's better to fix the distal lesion first, because the proximal lesion assessment is affected more by the distal lesion stenosis rather than the other way around, okay? So if you have sequential lesions in an artery and you need to do an FFR, you should assess the distal lesion first, fix that lesion if you think it's important, and then reassess the proximal lesion, because the numbers can change. This was a significant stenosis, it's changed to 0.74. Sometimes it changes even more than 0.8, and then you don't need to touch the proximal lesion. The circumflex lesion, if you look at it, it looks maybe significant to some people, but again, FFR was okay. And the LAD, mid to distal LAD, the FFR was okay. So both of these lesions were left alone. This lesion was obviously fixed. So it's very valuable in the assessment of multivessel disease. The FAME trial you probably heard about tried to assess fractional flow reserve assessment versus angiography for multivessel disease. So they took patients with multivessel disease and they did angiography and they wanted to make a decision whether to stent or not stent based either on coronary angiography or on FFR. And when they followed these patients for over a year looking for survival-free of MACE, they found that there was a substantial difference, significant difference in favor of our guided PCI. So again, in patients who have intermediate lesions where you're not sure about the hemodynamic significance of a lesion, if you do an FFR on these patients and you follow these patients, patients who had FFR-guided PCI did much better than those who had angiographically guided PCI with an absolute difference of 5.1 at 360 days in terms of survival free from MACE, which relates to about 30-35% reduction, relative risk reduction in MACE. What about left main stenosis? Those who attended Dr. Al-Haddad lectured when he talked about the left main. The left main creates a lot of problem for us interventionalists because it's very difficult to assess the ostium and it's also very difficult to assess the distal lesion. In the ostium, you have the angulation, you can also have spasm from the catheters. Sometimes you look at the lesion and you think there is a significant ostial left main disease where in fact there is no lesion. And sometimes in the distal left main, you can see this phenomenon here and you don't know if this is a plaque producing stenosis or this is just the normal tapering of the left main before it branches into LAD and circumflex artery. So if you look at here, someone may just assess this as a significant lesion and proceed with complicated or complex bifurcational stenting, where in fact with FFR, it's very easy to prove that this patient does not have a stenotic lesion in the left main and this patient should be left alone and not stented. Again, this is a patient with a mid left main disease. Look here. Most of us will assess this lesion as 30 to 40%. We'll probably just say, okay, go home. You have some disease in the left main. You don't need to be stented. Bye-bye. But this patient, when an NFR was done, it was 0.74. So by criteria, this patient needed a stent if that patient was symptomatic. So again, this is just to show you how visual assessment of coronary stenosis is sometimes extremely misleading. We use FFR sometimes to assess diffuse disease. When you have a lot of lesions and the vessel is diffusely diseased, and this creates a problem. Even if you don't find discrete lesions in a severely and diffusely diseased segment, you can have low FFR. So sometimes it's very useful to do a pullback FFR assessment from distal to proximal LAD, and in this patient there was a significant drop in this lesion at 1. So there was a significant drop in the FFR, meaning that this lesion here in the mid-distal LAD was significant, but the rest of the LAD from 2 to 1 was not really significantly stenosed. So you can proceed to stent that lesion and leave the other lesions alone. Can we do FFR in an acute myocardial infarction patient? There is a problem. You know, the FFR assessment depends on proximal flow, but also depends on distal flow and how much there is blood flow in the distal bed. So in the presence of a scar tissue where there is no flow, the scar tissue will lead to underestimation of the severity of stenosis because there is no flow, so there is no gradient. If in the case of a normal myocardium, if you have a lesion that is 75% stenosed, this will give you an FR of about 50-50. So this is a significant lesion that needs to be tackled. In the presence of a myocardial infarction, because of substantially reduced flow in the distal bed, that same 75% lesion will now give you an FR of 0.84. So the presence of scar in the myocardium will tend to underestimating the severity of stenosis, will give you a falsely high FFR value. So you have to be careful when you assess this. However, in patients who present with an acute myocardial infarction, you still can assess the non-culprit lesions. So if you have a patient with an acute ST elevation anterior wall myocardial infarction, and you know that the LAD is the lesion, you proceed to do the LAD, you put a stent, everything, but then that same patient has a lesion in the circumflex, under the RCA, that looks somehow mediocre, and you need to assess that lesion. Can you do that with FFR even in the phase of an acute myocardial infarction? Yes, you can. And this is just to show you that in the acute phase, when non-culprit lesions were assessed, and then they were assessed later at follow-up, they gave the same result in terms of FFR assessment. So FFR in an acute myocardial infarction should not be done on the acutely, on the culprit vessel, but can be done on the non-culprit vessel. If you need to do FFR on a culprit vessel, suppose you have a patient who has a proven ST elevation myocardial infarction, but you took that patient to the cath lab, you've administered thrombolysis, and the clot has dissolved, but leaving a mediocre lesion, 50 to 60%. You need to know if this lesion is okay. Then you have to wait about 5 days minimum, send the patient to the CCU, to the ward, and then in 5 days, if you want to make an assessment with the FFR, you can bring the patient back and do an FFR on the culprit vessel. But acutely, you shouldn't, okay? Because that will give you, will tend to underestimate the degree of stenosis, will give you a falsely high FFR. Now, recently, I don't know if any of you attended the last ESC in Munich, but the FAME2 was presented there, and the FAME2 is different from the FAME1. FAME1 was randomizing patients to optimum medical therapy versus FFR-guided PCI. And here in FFR-guided PCI versus medical therapy in patients with stable coronary artery disease. The 1-year results were reported a few years ago, but recently they reported the 5 years ago. And this is just to show you that if you treat patients, if you do PCI, FFR-guided PCI to patients, when you compare that to optimum medical therapy, there is quite a difference in terms of reduction of MACE in favor of FFR-guided PCI. So it really works. And when they combine the results of FAME2, the NAMI3, and compare Acute, which are 3 studies that looked at that, not only that you get reduction in MACE with FFR-guided PCI versus medical therapy, but there was also a reduction in cardiac death and myocardial infarction. And this is important because in PCI, we know that PCI reduces ischemia, recurrent revascularization, but we don't know yet the effect. We don't have any evidence that performing angioplasty or stenting on patients with coronary artery disease improves mortality and rate of recurrent myocardial infarction. So this is very reassuring that when you perform FFR-guided PCI to patients with stable coronary artery disease, that you can get long-term reduction results in terms of reduction of MACE, reductions of urgent revascularization, or reduction in death and myocardial infarction. There are some pitfall limitations of FFR. One of them, as I said, is an acute ST elevation myocardial infarction where you have to wait 5 days if you want to assess the culprit lesions, but you can use it to assess non-culprit lesions. Submaximal hyperemia is a problem. If you want to do FFR properly, you have to produce maximal hyperemia. So you have to give the proper dose of adenosine for the proper time, and then make sure that you do your assessments during the infusion of adenosine. Because if you don't do that, then you also get an underestimate of the degree of stenosis. And this is just to show you that so the third one, I'm sorry, this relates to the third point. The third point is you have to make sure your guiding catheter is not hugging the ostium of the coronary. Because if it's hugging the ostium of the coronary and the pressure is damped, then the pressure at the tip of the guiding catheter will not be the systemic or the central aortic pressure. It will be rather the damped pressure of the proximal coronary artery. And therefore, this can give you a false negative FFR and a normal FFR, where, in fact, if you put the catheter back and you get true central aortic pressure, then you can get a difference. So always when you're doing FFR, make sure that your guiding catheter is not hugging, is not damping the pressure, and the ostium of the coronary artery is free and there's blood flow. Sometimes you get falsely high readings with FFR, and this can occur in different situations. I don't think we have time to go over these, but this is interesting that sometimes if you are doing a patient and you say, this patient, I'm sure I'm going to do the FFR because this lesion is very stenotic, the patient has angina, he has ECG changes, and I just want to do an FFR just to be objective, but you're hoping or you're assuming that the FR is going to be low and this patient will need a stent, and then all of a sudden you get an FR of 90, of 0.9. And then you say, it doesn't make sense. I mean, this lesion looks very severe and the patient is symptomatic and there is no other lesion, and I'm sure this is angina. There are situations where you can get falsely high FFR. Some of them are related to the heart, to the technical way you do the FFR, but some of them are related to other factors. And then you have, really, when you're faced with this situation, you have to consider the presence of other factors. Now, having said all of that, still, this is from 2018, the global penetration of FFR-guided PCI is below 8%. And having said that, having shown you all the benefits of FFR in making the decisions in the cath lab, still not a lot of people are using FFR, even in rich countries. Why? Because it has problems. First of all, زي ما حكى محمود, it adds to the expenses. You have there's a price that you have to make, the price of the wire, the price of using the machine. And administering adenosine or any vasodilator is sometimes very uncomfortable to patients. It produces chest pains, it produces dyspnea, it leads to sometimes drop in the blood pressure. Sometimes patients feel that they're dying, and also some patients get bronchospasm, some patients even get arrhythmias, sometimes even ventricular arrhythmias, which would require a cardioversion. So there are problems associated with administering adenosine in these patients, as well as the expenses, which make FFR not really a very popular test. So the alternative to that was iFR. Okay, so iFR was introduced hoping to stay away from the problems that are associated with FFR. And with iFR, instantaneous wave-free ratio, what they said is that there is a phase in the cardiac cycle where there is nothing happening. It's called wave-free period. So nothing is happening, no contractions, no active relaxations, nothing is happening. If we measure flow at this period, it will give us the same information that we get with FFR. And remembering that FFR spans the whole cardiac cycle, yes, systole and all of diastole. So it's an average of blood flow during the whole cardiac cycle. But if we take that wave-free period in the cardiac cycle and we measure the flow, the resting flow, not the maximally hyperemic flow, the resting flow, that will give us identical information to the information that would get with FFR. The obvious advantage is there is no adenosine administered, so there are no side effects and complications to these patients. So that's what they did. And this technology, this was tested in studies comparing iFR to FFR, which showed that it is non-inferior to FFR. Mind you, you have to remember that the cutoff for ischemia in FFR differs from that in iFR. As I said, with FFR, it's 0.8, right? 0.75 to 0.8 is the gray zone. 0.8 is the cutoff for ischemia. FFR below 0.8 needs to be treated. FR more than 0.8, you can defer treatment. With iFR, the cutoff is now 0.9 or 0.89. Okay, so they're not the same numbers, and you have always to remember that. When they correlated iFR with FFR, you can see that the correlation is perfect. So if you do FFR assessment or if you do iFR assessment, at the end, you will get almost the same results in terms of determining whether your lesion is significant in terms of ischemia producing or not. And the defined flare study, which was also reported not too long ago, last year, looked at patients who were assessed with iFR and FFR, and when they looked at 12 months after randomizers looked at the event rate, it was identical. So whether you assess your patient with FFR or iFR, at the end of 1 year in the defined flare, the event rate was the same. But the advantage, as I told you, that if you look at the symptoms during performing the procedure, they were much less in iFR compared to FFR. More dyspnea, more chest pains, more rhythm disturbances, more hypotension, vomiting and nausea, bronchospasm, and ventricular tachycardia, and other side effects. They were all more with FFR because of the administration of adenosine. Okay, in the iFR Sweetheart, which looked at a patient population that is exactly like the defined flare study, but this was a registry. Again, they achieved the same conclusion that iFR was not inferior to FFR in terms of determining the need for intervention. And when the results of both studies were combined, you can see that the curves were almost identical or superimposed perfectly. So indicating that iFR is not inferior to FFR in assessing lesion, which is reassuring because this is a new technology, and any new technology, in order to prove its worth, it has to prove at least that it's not inferior to an older technology. So iFR was not inferior. Now, a lot of cath labs, a lot of places now advocate using the hybrid approach, which means that the reason for using iFR is because it's easier and you avoid the administration of adenosine. So you start with iFR, okay? You put the patient on the table, you put your wire, and you measure iFR. If the value of an iFR is more than 0.93, then you defer the patient. The patient does not need to be stented. You send this patient home. If the measurements are less than 0.86, and حكينا cutoff is 0.9, صح? If the measurements are less than 0.86, then this patient needs to be revascularized, okay? If the iFR number falls between 0.86 and 0.93, this is called the gray zone. So in these patients, you can do an FFR, okay? When you do an FFR on these patients, if the FFR is less than 0.8, then you can proceed. If the FFR is more than 0.8, then you can defer this patient. Doing this will save about 60% of such patients from receiving adenosine. So there are obvious reductions in cost, and there are also obvious reductions in patient symptoms related to adenosine. So a lot of places now are using this. They start with iFR, they do it. If they're not, they're not too happy with the result, if the result of the iFR falls between 0.86 and 0.93, then they can proceed with doing an FFR on these patients and then make an assessment. Of course, no talk is complete without mentioning FFR CT. This is not the subject of this lecture. I was asked to talk about FFR and iFR, but now we can also assess functional significance of coronary stenosis by doing FFR CT. This is a non-invasive modality. iFR and FFR are invasive. They're done in the cath lab, but you can do an assessment of stenotic severity non-invasively. When you do a CT scan, now we do a lot of CT scans for coronaries, you can take that data in the CT scan, send it to a company in the States, and they can send you the results back. And you, in doing that, you can have an FFR numbers or assessment of all segments of the coronaries. So at any segment of the coronaries, you can put your marker here and you can get an FFR. You can put it here, you can put it here. So you have an assessment of FFR in all segments of the coronaries. And this is obviously very important. So because it is non-invasive, and it may also help you in directing to whether you need to do catheterization or angiography on this patient, or you can send this patient home. So now you can do FFR, you can assess functional significance of coronary lesions non-invasively by doing FFR CT on such patients. I think with that, I come to the conclusion of my lecture. So thank you very much.